Hello, welcome to the DO webinar. I'm Professor Byung-Ho Choi at the Yonsei University in Korea. Today's topic is no graft for full arch restoration. I'm going to talk about how to do full arch restoration without bone graft and how to perform full arch restoration without gingiva graft. First, I want to show you why do I do full arch restoration without bone graft, and how could you do full arch restoration without bone graft? This X-ray shows a tooth with advanced periodontitis. Following extraction, the socket exhibits considerable bone resorption of buccal and palatal bone plates. I think that many dentists will perform bone graft for future implant placement. Have you ever wondered what would happen if we did nothing? If we did no bone graft, what would happen? It will gain additional bone, or it will lose more bone. I believe that there are many dentists who argue that such bone defects don't repair themselves. Therefore, we absolutely need to do bone graft. Is it real? To answer this question, I want to show you this patient. All the remaining teeth in the maxilla had advanced periodontitis. The teeth in the maxilla should be removed. This is 1 month. This is immediately after extraction. This is 1 month later. 1 year later, we obtained CV-CT scans, and we compared pre and after the tooth extraction. This is immediately after tooth extraction at the molar site. Look at 1 year after the extraction. Look at the buccal bone plate. The buccal bone plate has increased a lot. Let's take a look at another site, at the premolar site. It also shows the buccal bone plate was destroyed. This is 1 year after the extraction. Look at the healing process over the period of 1 year. The buccal bone plate has been regenerated. Look at another site, canine site. It also shows the bone level has increased a lot. Spontaneous. We did nothing. We did no bone graft, but the bone level has increased a lot. Let me show you another patient who had also advanced periodontitis. All the remaining teeth in the maxilla should be removed. This is immediately after the tooth extraction. We waited for 1 year. the edentulous ridge shows a very good shape. Let's take a look at the premolar site where there was a severe bone loss around the teeth. Look at the buccal bone plate. The buccal bone plate was destroyed 1 year after the tooth extraction. Look at the buccal bone plate. The level of bone has increased a lot. We try to virtually position an implant in the alveolus. It was possible to position the implant within the alveolus without exposing the implant surface. Look at the canine site. This is immediately and 1 year after the extraction. You can see here some horizontal bone resorption occurred, but it was possible to position an implant in the alveolus. Look at the inside the site, immediately 1 year after. Look at that, some horizontal bone resorption. We tried to place an implant in the area, but we were not able to position an implant within the alveolus. Look at on the other side. The other side also showed some horizontal bone resorption. We tried to place an implant in the alveolus. It's possible to position an implant within the alveolus. Except for the anterior site, we were able to place 6 implants within the alveolus. Look at each planned implant site. There was sufficient bone width and height to place those implants. We planned all 6 implant treatment. Immediately after implant placement, we did an immediate restoration. We connected the multi-abutment and the cylinders to the implants. This shows immediate restoration. The panorama shows all implants were placed as planned. We studied 48 patients who underwent tooth extraction due to advanced periodontal diseases. CBCT scans obtained before tooth extraction or 1 week after tooth extraction and at 1 year post-extraction from the maxilla and from the mandible. We evaluated the change of the extraction site over the period of the 1 year. It was amazing result. The mean vertical bone gain was 3.5 millimeters. The mean horizontal bone width gain was 5.5 millimeters. How could it happen? One of the key factors might be the observation period. We have waited for 1 year. Unfortunately, most of the previous studies have observed the socket healing only for a short duration, such as 3 months or 6 months. In infected socket, bone healing occurs very, very slowly. That's why we have observed the bone healing for 1 year. The second reason might be the extraction procedure. We used a flameless procedure to do extraction. Let me show you the effect of the flameless extraction on socket healing. These are dog's mandible. On one side of the mandible, the premolar was removed using a flap procedure. On the other side, the premolar was removed using a flameless procedure. This is 1 month after the extraction. You can see here, the flap extraction site shows inflammation, whereas the flameless extraction site showed very good healing state. This is 6 months after extraction. We obtained micro CT scans at the extraction site from 5 dogs. The results show that the flap group showed more bone resorption of the extraction socket than the flameless group. It suggests that the flameless extraction procedure can decrease bone resorption of the extraction site. The third factor may be no socket debridement. We believe that the granulation tissues in the infected socket is very bad for bone healing. Therefore, we try to get rid of the granulation tissues and have a clean alveolus with no evidence of fibro tissues. I used to believe that, but I changed my mind after meeting this patient. When I met her, she told me that the premolar in the left maxilla were very, very movable and removed spontaneously at home 1 month ago. The teeth were originally scheduled to be removed by a dentist due to advanced periodontitis, but they were removed spontaneously at home. She might not have performed socket debridement. The granulation tissue might have been left in the socket. But look at the extraction site. The extraction site showed very good healing. Since then, I changed my mind. What I did was a simple flameless tooth extraction, copious saline irrigation into the extraction site, no socket debridement, and suture if necessary. This is immediately after a simple Flemish tooth extraction. 1 week later, 1 year later, you can see here very good shape of edentulous ridge. We were able to position 6 implants in the edentulous ridge without bone graft. It has been reported that multipotent stem cells are present in infected granulation tissues, which means that the removal of infected granulation tissues may result in the removal of stem cells. They have also reported that the granulation tissue might be useful for bone volume enhancement. That's why we prefer natural bone healing rather than GBR for full arch restoration. Let's take a look at the bone quality at the GBR site. This is dog's mandible. We made 3 holes in the dog's mandible. The first hole was filled with bios particles. The second hole was filled with bios particles mixed with PRF, platelet-rich fibrin. And the last hole was left empty. And then the site was covered with a membrane. And then we waited for 1 month. Which one do you think will get the best bone formation? You may think the second hole, bios particle with PRF. Let me show you the result. This is a specimen from the bios particle site. There is a space between bios particles. The second hole, bios and PRF site, shows also there is some space between the bios particles. But it was a little bit better than the first site. Let me show you the final site, natural bone healing site. The hole was completely filled with a new bone. This shows our body's ability to generate new bone. We have believed that bone graft material promotes new bone formation. Based on the evidence, it might be wrong. What I believe is that bone graft material can disturb our body's ability to form new bone. Let me show you a clinical case. The tooth had advanced periodontitis. After removing the tooth, the socket was filled with this bios collagen sponge. This is bios collagen sponge. The collagen sponge was put in the extraction site. You can see here the bios collagen sponge in the socket. We waited for 1 year, and then we evaluated the bone, the healing of the bios collagen sponge. It seems there has been bone formation. It seems that the bios collagen has become hard over the period of 1 year. We collected a specimen from the site. We collected other specimens from patients as well. This is a collected specimen. Some specimens shows bios particles in the specimen. Some other specimens showed it's not hard, it's soft. This shows a microscopic view of the specimen. Sometimes there has been bone formation around the bios particles. Most bios particles were surrounded by connective tissue. Some specimens show that bios particles were surrounded connective tissues. That's why we can often find loose particles 6 months after GBR. Look at the natural bone around the implant. Beautiful, isn't it? Look at the GBR site bone around the implant. Even though you can generate new bone formation around implant, the quality of the bone between the natural bone and the GBR bone is completely different. I like the natural bone quality. Let's move on to the second solution. How could you do full arch restoration for full arch restoration without bone graft? The second solution is bone reduction rather than bone augmentation. In this situation, following tooth extraction, we don't try to build up new bone shape in this situation. What we prefer is bone reduction. If you perform bone reduction, it will widen the alveolar ridge, and then you can place implant. In this situation, we do bone reduction immediately after tooth extraction. Then you can place implant like this. The alveolar ridge is too narrow to place on implant. In this situation, we don't try to build up new bone shape. Instead, we cut the bone and place implant like this. This video shows bone grinding. We don't like bone grinding. Instead, we do bone cutting. If you cut the bone, you will get a bone segment. You can cover the exposed implant surface with the bone segment collected from bone reduction, like this one. In the case of insufficient prosthetic space, if you do bone reduction, you will have a sufficient prosthetic space. Let me show you this patient. She suffered from advanced periodontitis and periapical abscess. You can see here a fistula from the lateral incisor. First, we put markers on the alveolar crest, and then we obtained intraoral scan image and CBCT scans. On the merged image, we do implant planning. We do Oron 6 implant planning. We decided bone reduction at this level. On the merged image, we designed this bone reduction guide, which consists of a top part and a foundation part. The foundation part guides bone reduction. A surgical guide was designed, which is connected to the foundation part. The border of the bone reduction guide is located at least 5 millimeters away from the mental nerve to avoid damaging the nerve. This is the 3D printed bone reduction guide. This is a printed surgical guide. We prepared a provisional denture to do immediate restoration. We have also prepared cylinders and rubber dam sheets to do immediate restoration. The mandible is exposed only on the labial side. You don't need to raise the flap on the lingual side. This can decrease the swelling on the lingual side after the operation. After fixing the bone reduction guide, the teeth were removed and then bone reduction was performed. After bone reduction, the surgical guide part was connected like Lego pieces. And then we placed implants and we did immediate restoration after connecting the abutment and the cylinders. The cylinders were bonded with a provisional denture to do immediate restoration. And then we converted the provisional denture to a fixed bridge by doing the laboratory work. You can see here the finished provisional bridge. You see here the provisional fixed bridge is placed in the patient mouth immediately after implant placement. This is a facial photo immediately after implant placement. 6 implants were placed as planned. Let's move on to the third solution, how to do full arch restoration without bone graft. The third solution is to use a screw retained system rather than a cement retained system. Let's take a look at the cement retained system. If you look at the inside of the cement retained prosthesis, there is either a commercial abutment or a customized abutment. The crown is cemented onto the abutment with cement. For the cement retained full arch prosthesis, you need 8 or 10 implants in the maxilla and 6 or 8 implants in the mandible. This shows the interarch space The interarch space is very important to make teeth. If the interarch space is similar to the crown height, you can make beautiful teeth using the cement retain system. But if the interarch space is larger than the crown height, you will get extended crown height. The aesthetics of the prosthesis is compromised. Look at the emergence profile of the cement retain system. It's not good for cleaning. It's difficult for cleaning the implants. Look at the crown shape at the incisor site. The crown shape is not optimal because of a little bit displaced implant position. In cement retain system, you need to place implant exactly where you will make teeth. Each implant site, 8 or 10 implant site, should have a sufficient bone width and height to place implant. Otherwise, you need bone graft. That is the cement retain system. But if you use a screw retain system, you can place implant wherever there is bone, no matter where you place implant. For the screw retain system, you need just 4 or 6 implants in the mandible and in the maxilla. There is a lot of opportunity to find 4 or 6 implant sites where you can place implant. If you use the screw retain system, you need fewer number of implants than the cement retain system. If you use the screw retain system, you can make more beautiful teeth than the cement retain system because you can make interproximal papilla, gum, and good emergence profile. If you treat your patient with the screw retain system, your patient will pay less money for the treatment. What is your justification for using the cement retain system? We need to explain to our patient why it is the right thing to do. Let me explain the procedure for screw retained full arch fixed restoration. First, you need to put markers, image merging, implant planning, fabricate a provisional denture, implant placement, immediate restoration, scanning the provisional prosthesis, fabricate a final restoration, and then final restoration. That is the workflow for a screw retained full arch restoration. Let me show you about markers. There are 2 types of marker, an intraoral marker and a denture marker. You can put intraoral marker in the mouth using light curing resin, but it is movable. It is not stable. It can fall off. You need a special glue to fix the intraoral marker. This is the glue. After applying the glue, the marker is stable. This is the glue, cyanoacrylate adhesive. We call it histoacryl. This is the denture marker. Denture marker, you can use either an alumina marker or a light curing agent marker. After taking impression, you can put the markers on the denture flange using light curing resin. The bonding strength is strong enough. Therefore, you don't need an additional glue to fix the marker. If your patient is wearing a denture that has a metal framework, the metal produces scattering artifacts in the CBCT scan. If you have a scattering image in the CBCT scan, you cannot merge the image with the intraoral scan image. In this case, you can use a wax denture. This is a wax denture. Wax dentures are commercially available. There are different sizes of wax denture. You can choose one of them and you can adjust the shape to the patient anatomy. It is made of wax, therefore you can make it soft by putting them in the warm water. If you put it in the warm water, you can reshape, you can bend it, you can adjust the shape. After taking impression, you can establish the vertical dimension by cutting the occlusion part. Therefore, if you use the wax denture, you can take impression and jaw relation record simultaneously. After taking impression, you need to put the markers on the denture, and then you need to scan the denture. You can get this intraoral image by scanning the wax, scanning the denture, the opposite teeth, and the bite scan. The next step is to invert the denture image. Then you will get this intraoral edentulous image. You need to take a CBCT scan. On the merged image, you can design this provisional denture. This is a designed provisional denture. You can print it. You can make a gum color using this light cured coating material. The provisional denture contains cylinder access holes, which helps bond the cylinders with the denture. this is a provisional bridge, which was converted from the provisional denture. This shows a 3D printed denture. You may think that it's possible to fabricate the denture by milling PMMA blocks. If you compare milled dentures and 3D printed dentures, if you use a milling machine, it takes about 8 hours to fabricate one single milled denture. But if you use a 3D printer, it takes about 40 minutes to fabricate one 3D printed denture. How about cost? The milled dentures are a lot more expensive. The most significant difference is that the structure of the provisional denture is too complicated to make it by milling. You can use this small 3D printer to fabricate the provisional denture. This is a scan image of the provisional prosthesis. Using this scan image, you can design and fabricate a final prosthesis. This is a final prosthesis. We use a provisional prosthesis scan method to design and fabricate a final restoration. You can also use a scan body scan method. If you compare two methods, if you use a scan body scan method, you need to scan 3 times. The first scan is without scan bodies. And then the second scan is with scan bodies. And then you need the third scan is to scan a bite. In total, it takes about 40 minutes to get a data to design and fabricate final prosthesis. This is scan body scan method. If you use a prosthesis scan method, it takes only about 40 seconds to get a data to design a final prosthesis. From the aspect of scan time, it's a great difference between them. 40 minutes or 40 seconds. From the aspect of scan accuracy, there is a significant difference between them. The prosthesis scan method is a lot more accurate than the scan body scan method. Therefore, I would like to recommend to use the prosthesis scan method to design and fabricate a final prosthesis. Let's move on to our final topic: how to do full arch restoration without gingiva graft. First, I want to show you why do I do no gingiva graft in the case of lack of keratinized occult gingiva. Look at this patient who has a very limited keratinized occult gingiva in the edentulous region. 2 implants were placed. Look at the buccal mucosa. The mucosa has a direct contact with the implant surface on the buccal side. This shows 2 years after implant placement. There was no problems at all. Let me show you another patient who has also very limited keratinized occult gingiva in the edentulous region. 3 implants were placed 3 years after implant placement. There was no problem. No bone loss around the implants. Let's take a look at another patient. Look at the buccal frenum. Has a direct contact with the implant surface. This is immediate after implant placement. This is immediate after immediate restoration. 1 year after the implant placement, the soft tissue showed a very good condition, even though there was a lack of keratinized occult gingiva. What we have observed is that the mucosa can change to the keratinized occult gingiva. Look at this case. When 2 implants were placed, there was no keratinized gingiva on the buccal side of the implant. But 10 years after implant placement, there was a new keratinized occult gingiva around the implant prosthesis with a thickness of 2 or 3 millimeters. Look at this case. Before implant placement, there was no keratinized occult gingiva, but 5 years after implant placement, there was new keratinized occult gingiva around the implant prosthesis. We believe that the mucosa has the potential to create new keratinized occult gingiva. Look at this edentulous patient. The patient had a very narrow keratinized occult gingiva zone. We placed 4 implants in the area without a gingiva graft. 1 year after implant placement, there was no problem, even though there was no keratinized occult gingiva on the buccal side and the ringal sides. Look at another patient. She had a very narrow keratinized occult gingiva. 4 implants were placed in the area. This is immediately after implant placement. This is 1 year after implant placement. There was no problems, even though there was no keratinized gingiva on the ringal and buccal side. No bone loss around the implants. Look at this patient. When implants were placed, there was no keratinized gingiva on the labial side. This is 4 months after implant placement. This is 2 years after implant placement. Look at the change. The mucosa has become strong enough to sustain the irritation from function. My message, what I want to say is that if there is sufficient keratinize or the gingiva, place implant in the area. Then it's easy to place implant. It's easy to clean the implant. It's easy to keep them in healthy condition. But if there is a lack of keratinoid or the gingiva, try to place the implants in the existing and remaining keratinoid or the gingiva area as much as possible without gingiva graft. Let me finish off my presentation. You can do full arch restoration without bone graft using natural bone healing, bone reduction, or a screw retain system. You can do full arch restoration without gingiva graft because the mucosa has the ability to become strong enough to survive. Thank you very much for your attention. I hope you enjoyed today's lecture. Stay safe and see you soon again. Thank you. Bye-bye.